Good afternoon, everybody, and I would really like to thank the TAFS organization for inviting me here today and to talk with you about my work. In 2022, I defended my PhD thesis, and during my thesis, I've investigated the optimization of healthcare throughout life for patients born with esophageal atresia. And as you can see in this figure, which is also part of the discussion of my thesis, I tried to study the whole circle of life. We start with the development of esophageal atresia. I studied the formation of anastomotic strictures in the first year of life, comorbidities and the quality of life during childhood, and finally also the transition to adult healthcare and the problems that adults can encounter during that time and during adult life. And for this presentation, I was asked to discuss with you this last part, the transition to adult healthcare. And I will talk with you about gastrointestinal problems, pulmonary problems, endoscopic surveillance, and a little bit about genetics. In this figure, I've shown the pediatric follow-up for esophageal atresia patients in the Netherlands. And as you can see, it is very well organized. For almost 25 years now, patients come into the hospital at standardized time points, starting at 4 months old and the last one at 17 years old. I will not go into detail because we're going to talk about the adults, but as you can see, it's really a multidisciplinary program. A psychologist is involved, a physiotherapist is involved, a pulmonologist is involved. But the last visit is at 17 years old. So what happens when you turn 18? For a long time, this is where it ended. The last visit was at 17 years old, and nothing was known about follow-up in adulthood, and it was also not known that follow-up in adulthood was even required. Like I said, for a long time, also in the Netherlands, also in Rotterdam, there was no adult follow-up, but in 2013, we started the screening and surveillance program. I will come back to this later. Because first of all, I want to talk to you with you about the healthcare needs of adults. A common saying in medicine is that children are not small adults, but the same thing also applies the other way around. The problems that adults born with esophageal atresia encounter during life are not the same as the problems that children face in daily life. Therefore, we started by investigating these healthcare needs. What is it? What are the problems that adults born with esophageal atresia face? And most importantly, what do they think about those problems and what is important to those adults? And we did so by organizing 2 focus group interviews, one with the adult patients and one with the family members of adult patients. And a focus group is a small group of 10 to 15 people of the same population and is always led by a moderator, in our case, a neuropsychologist. The moderator gives a topic to the focus group. The focus group is encouraged and stimulated to discuss this topic until saturation is reached. And saturation means that no new information is added to the discussion. The topics that we introduced to the, introduced to the focus groups are listed here on the slide, and they were set in advance by an expert panel. The expert panel consisted of a pulmonologist, a gastroenterologist, a dedicated researcher in the field of esophageal atresia, a pediatrician, a psychologist. So also the expert panel was very multidisciplinary with the goal to make it also cover all aspects of life. These focus group interviews were literally transcribed and they were coded, the text was coded and the codes were organized into themes. The whole goal of this process, which is called a thematic analysis, is to look for similarities. This is quite a large table and I don't expect you to read it in detail, but this summarizes the results of these focus groups. And in this table, we also use as a guide for physicians when they ask us what is important for adults born with esophageal atresia, for example, general practitioners. And most importantly, a few things stand out that I want to discuss with you. The gastrointestinal and pulmonary problems are still experienced on a daily basis in some patients. Some patients have problems with like dysphagia, reflux, coughing, frequent pulmonary infections. These are all the things we heard in the earlier presentation in childhood, but there are also adults who are still facing these problems frequently. Mental health is also a large topic. Many adults experience emotional distress or anxiety for medical procedures due to experiences in their childhood. Some adults have problems with how or even if they want to tell the people around them that they are born with esophageal atresia. Some adults are having a hard time at work, for example, during lunch breaks or when they need to take a personal day to visit the hospital or are worried about not getting a promotion. And last, and these are two very important things, I think, is that the patients in the focus group really pointed out that it's very important that there is one coordinating physician who coordinates their follow-up, that they have one person coordinating their whole healthcare, and secondly, not very surprising, but that the general practitioner usually knows way too little about their condition to help them with this. So now we know what the most important healthcare needs of adults are, but what are we going to do with that? To address the gastrointestinal and the pulmonary problems, it is important to organize follow-up possibilities with expert specialists. So follow-up with a gastroenterologist and a pulmonologist are the basics for that. During these consults, it's important to also pay attention to the emotional distress and other issues that influence the quality of life of these patients. To this end, we have developed the SQUIA questionnaire, and SQUIA stands for Specific Quality of Life of Esophageal Atresia Adults. And the SQUIA questionnaire is a tool that can be used preliminary to the consult. Currently, it is implemented in the Netherlands, in the Dutch healthcare, and patients are going to complete the questionnaire prior to the consultation, with the goal to make the consultation in one way more efficient, but in another way also to open the door to discuss the other aspects of life. For example, the psychological problems, anxiety. We feel that it's more easy to check a box and then make it discussable within with the doctor, instead of that you have to bring it up yourself. Also, this questionnaire is currently being translated and validated throughout Europe in the hope that we're going to use it also in other countries. And we're also working on that here in the UK. And all of these aspects needs to be coordinated of the follow-up. All these aspects of the follow-up needs to be coordinated by one person or one dedicated team. So let's start with the gastroenterologist. Why is follow-up needed? First of all, of course, to discuss and wherever possible treat the physical complaints that patients experience. But also another reason is the increased risk of a Barrett esophagus. Barrett esophagus is a condition in which the epithelium of the squamous cell, squamous cells that are supposed to be in the esophagus change into cylindric cells, columnar epithelium that is supposed to be in the stomach. So like you see here, the mucosa of the stomach is kind of shifting up towards the esophagus. 10 years ago, my colleague Floor Vergouwen already performed the literature research and found an increased reported prevalence of Barrett esophagus and esophageal carcinoma in patients born with esophageal atresia compared to the general population. Also, these patients were at a much younger age than the general population. And this has led to the start of our screening and surveillance program in 2013. In this program, every patients undergo a gastroscopy every 3 to 5 years, depending on their age and potential outcomes of earlier endoscopies. And during these endoscopies, biopsies are taken according to a standardized protocol, and these biopsies are reviewed by a pathologist under the microscope. And in 2022, we have published the results of the first 8 years of this surveillance program. During this period, almost 400 gastroscopies were performed in a total of 271 patients. And for the quick calculators among us, that means that over 100 of them also already had a second or a third endoscopy. And that means that we can also say something already about follow-up results. What did we find during these surveillance endoscopies in a period of 8 years? Our patients' ages ranged in this program from 15 to 68 years old. 19 of the 271 patients, so 7% of them, had a Barrett esophagus at a median age of 32 years. 4 of them developed a Barrett esophagus during follow-up, meaning that the first endoscopy was clean, and with their follow-up endoscopy, the second endoscopy, a Barrett esophagus was found. At the time of the diagnosis of Barrett esophagus, patients were median 32 years old. However, the youngest patient with a clinically relevant Barrett esophagus, fulfilling this internationally set of criteria and requiring more intense, more frequent follow-up, was 20 years old. And last, during this time period, unfortunately, 2 patients were detected with esophageal carcinoma who were not under follow-up and not under surveillance. Based on these results, we have made some alterations to the surveillance program. First of all, we now start screening at 20 years old instead of 17 years old. This lowers the burden for young adolescents and is still proven to be safe. We have proven with our data from 8 years of surveillance that it is safe to start at 20 years. Secondly, up to the age of 40 years, patients will be offered an endoscopy every 10 years, and after the age of 40, every 5 years. This was respectively 5 and 3 years, with the cutoff at the age of 30. In the last 2 years, our cohort keeps expanding. Both children becoming adults from our pediatric hospital, but also adults coming in from other hospitals, or even sometimes other countries. Of course, it is also interesting to wonder why patients born with esophageal atresia develop a Barrett's esophagus more often. Could this cause perhaps be genetic? Over the last 10-15 years, several PhD theses have been devoted to discovering genetic defects causing esophageal atresia. You hope to find one central gene, when there is something wrong with this gene, then esophageal atresia occurs. But this central gene has not been found so far, and we don't really think that there is going to be one central gene to point out. However, multiple genetic variations and genetic syndromes have been associated with the development of esophageal atresia. And this made us wonder whether these genetic variations could also be found associated with the more frequent development of Barrett esophagus. And to this end, we have compared the DNA of these patients. We took biopsies of patients born with esophageal atresia who have developed a Barrett esophagus, and patients who were born healthy and also had a Barrett esophagus. We extracted the DNA from the biopsies and compared the data. What we found was a higher genetic predisposition, meaning that genes associated with Barrett esophagus were more frequently present in esophageal atresia patients compared to the healthy adults. Also, we found that genes involved in inflammatory responses, stress responses, and oncological processes were more frequently disturbed in esophageal atresia patients compared to healthy borns. Another thing that we wondered was if esophageal atresia patients may also respond differently to reflux episodes. We know that reflux is more common in esophageal atresia patients, but what if they are not only exposed more, but also respond more heavily to this exposure? To simulate this, we set up an experiment. We used fibroblasts of patients born with esophageal atresia and of healthy controls. And fibroblasts are actually skin cells, and these skin cells can be compared to the squamous epithelium of the esophagus. And the reason that we did this with fibroblasts instead of the biopsies is, of course, that it's not ethical to just take biopsies with a gastroscopy from healthy controls. So therefore we chose the next best thing, and we chose for the fibroblasts. The fibroblasts were grown in a Petri dish, either in a normal medium with a normal pH, or exposed to acid for 30 minutes. And after the cells were fully grown, we extracted DNA from the fibroblast and we compared the results. We found similar results in this experiment as in the previous. So again, we found disturbances in genes involved in the inflammatory stress response and oncological processes, and there was an overlap between the biopsies and the results of the biopsies and those of the fibroblasts. Altogether, these results contribute to the puzzle, but again, no central gene could be detected, and similar to the development of esophageal atresia itself, it seems to be a multifactorial cause. For the last part, I would like to tell you a little bit about the pulmonary follow-up. In 2019, the Center for Congenital and Perinatal Pulmonary Diseases was founded. In this center, they treat multiple conditions next to esophageal atresia. At this moment, 277 patients born with esophageal atresia have visited the center for follow-up. During the intake, which ideally takes place at 17 years old, patients undergo a lung function test, a CT scan, and consult the pulmonologist. The results of the first 180 patients have been analyzed and will be published very soon by my colleague Stephanie Wintels, who is a new PhD student in our department. To conclude, it is important for healthcare professionals to realize that many adults still experience gastrointestinal and pulmonary problems on a daily basis. A multidisciplinary follow-up program is necessary, but with one coordinating physician. In practice, that is most likely the gastroenterologist, but could also be the pulmonologist, or is discussable in every hospital for itself. This follow-up program should not only pay attention to these physical problems, but also to the mental health, socio-economic problems in daily life, of course, the gastrointestinal and the pulmonary complaints, endoscopic surveillance to detect Barrett esophagus in an early stage is important, and of course the involvement of the pulmonologist. If you have any additional questions after this presentation, I'm happy to, of course, answer them now. But this is the email address of the national email address for follow-up in the Netherlands. And though it is for the Dutch patients, we are always happy to also answer your questions wherever possible, or refer you to the right, in the right direction for the right type of follow-up. And with this, I would like to close my presentation. And I'm happy to answer any questions.